Right. Hi, everybody. We are going to get started. Thank you for being here today. My name is Amy Forbes. I'm the training manager from the Northwest Mental Health Technology Transfer Center. I'd like to welcome you all to today's webinar on screening, assessment, and brief interventions for eating disorders in community mental health settings, sorry. Presented by Megan Riddle and Natalie Goodwin. Please know this webinar is being recorded. A certificate of attendance will be emailed to those who registered and attended, and we are not able to offer CEUs for this webinar. I'm going to give a brief overview of our network and some important information before we get started. The Mental Health Technology Transfer Center is a nationwide network supported by the Substance Abuse and Mental Health Service Administration, or SAMHSA. Our network includes 10 regional centers and a network coordinating office. And you can see in the pink circle at the top of your screen, our Northwest MHTTC covers HHS Region 10, which includes Alaska, Idaho, Oregon, and Washington. Our goals at the Northwest MHTTC are to support mental health-related evidence-based practices, heighten awareness, knowledge, and skills of the behavioral health workforce, foster alliances and address diversity of training needs, and to share free publicly available training and technical assistance. Our area of focus is in evidence-based practices for psychosis, including CBTP and assertive community treatment, or ACT. We also provide a number of other trainings and topics. You can check them all out on our website. On our website, you can register for free webinars or learning communities, watch a recorded webinar, take a free online self-paced course with healthy knowledge. You can sign up for our weekly newsletter, review our resource library, or listen to our podcast called Putting It Together. So for today's webinar, we will send out a link to the recording, the slides, as well as your certificate of attendance within a couple of weeks after this event. For communication during the event today, please use the chat box to reach out to our staff if you need any assistance, or if you would like to share your respectful comments, greetings, and observations with everybody. Please use the Q&A box to type your questions for our presenters. You can do this at any point throughout the presentation. We will be monitoring the Q&A box to facilitate answering as many questions as possible at the end of the presentation. Also, at the end of today's event, we will send out a link to our survey. Please know your feedback is very important to our work and the content that we provide. We are required by SAMHSA to conduct this survey, yet they do not have an official position on our content. And we'd just like to share a couple of upcoming events that we have Leah post. She works at Perfectly Queer Counseling here in Seattle. On July 26th, Leah will present on intersectional feminist approach to therapy. And then on August 2nd, Leah will be back presenting on queering supervision, how to bring your authentic self to the supervision space. You can register for both of these webinars on our website. And now I'd like to welcome and introduce all of you to today's presenters. Dr. Megan Riddle is board certified in both adult psychiatry and consult liaison psychiatry. She attended Western Washington University for her bachelor's and master's degrees, and then went on to Weill Cornell Medical College, where she earned a medical degree as well as a PhD in neuroscience. She completed her residency and fellowship training in psychiatry at the University of Washington. Dr. Riddle is currently a courtesy clinical instructor with the University of Washington Department of Psychiatry and Behavioral Sciences, and the medical director at the Eating Recovery Center in Bellevue, Washington. She has a particular interest in inclusivity in eating disorder treatment and research, with a focus on transgender and gender diverse individuals. I'd also like to welcome Dr. Natalie Goodwin. Dr. Goodwin received her PhD in clinical psychology from the University of Alabama, Birmingham, and completed her pre-doctoral internship and postdoctoral fellowship at Baylor College of Medicine in Houston, Texas. Following the completion of her graduate training, Dr. Goodwin returned home to Seattle and served as a clinical manager and clinical director at the Eating Recovery Center in Bellevue for 6 years and spent 3 years in private practice. Her professional focus is on the area of treatment of eating disorders. Dr. Goodwin is certified in exposure and response prevention treatment for obsessive compulsive disorder and has also trained in CBT, DBT, and prolonged exposure for PTSD. I would like to welcome you both. Thank you so much for being here, and I will stop sharing and let you both present.
Hey, thanks so much for having us. Give me a second and I'll get the right screen up.
Yeah.
All right. So Dr. Goodwin and I are very excited to be here today. This is a topic we are incredibly passionate about, which is getting more eating disorder knowledge out into the community to help sort of raise awareness for this serious mental illness. So first of all, some disclosures. We're both affiliated with the Eating Recovery Center and the Pathlight Mood and Anxiety Center. We're sort of in the greater Seattle area, Seattle and Bellevue. We've got sort of all levels of higher levels of care. So we do intensive outpatient, partial hospital, and residential care here for all genders, ages 8 and up. Take a variety of insurances, including Medicaid for both Oregon and Washington, and some other states that I never can totally keep track of. So that's a little bit about us and our background. I just want to disclose that. So first of all, to start this talk, I do want to acknowledge that we come at this from a place of a lot of privilege for ourselves, and it is really important to consider eating disorder treatment in the context of our own intersectional identities and those of our patients and some of the power dynamics that creates. Eating disorder research and treatment has historically really centered white, able-bodied, neurotypical girls and women and their narrative, and really led to the exclusion of other individuals. And we'll touch a little bit on sort of why that's a problem. And it is really important to ensure that there are diverse voices included at the table when we're having these conversations about eating disorder treatment. So some objectives. We've got lots of goals for today. First of all, we'll talk about identifying who is at risk for eating disorders and how do we screen for them. I think these are some of the most important things for you to take away, because as members in the community, like, this can be a really pivotal role in the care of these individuals, is simply getting them identified in the first place. If you do nothing more than recognize an eating disorder may be going on, that can be incredibly helpful and transformative for the individual. We're also going to discuss sort of eating disorder interventions and treatment. We're going to give you sort of a broad bird's eye view of that and talk a little bit about, hey, when do you refer out? Like, when do you send someone to specialized care versus when do you try to sort of keep them in the community? And then we'll also be talking some about how do we support the people around the individual identified with the eating disorder? How do we support the family or the loved one, particularly if the person with the eating disorder is feeling pretty ambivalent about getting into care, which can be really normal. So first up, a case. We're going to talk about Alice. So you're a school counselor at a high school. Alice is a sophomore there. She does really well in school. She's generally a really engaged student. She has lots of friends. She's just like a really sweet, likable kid. Last year, she joined the track and field team as a freshman in order to improve her college education. She is real forward thinking about this. And teachers, though, are starting to notice some changes. Over about the last 6 months, Alice seems a little more withdrawn in class. She's often looking tired. Teachers are noticing that she's often dressing in kind of baggy clothing. They're like, ugh, something seems off. Um, Alice's mom is also noticing some changes, and she gives you a call because she's concerned. And she shares that Alice is spending the entire evening in her room at night working on homework. She's not coming down. She's not spending time with family. And mom notices, she doesn't even have time to eat dinner with us. And mom's concerned. Mom's like, I know there's normal teenager stuff. So, is this normal, or like, should I be worried about this? So we'll sort of use this case to frame some of the rest of our discussion. So you kind of keep Alice in the back of your mind. So why talk about eating disorders? Well, first of all, as I mentioned at the beginning, eating disorders are serious mental illnesses that carry with them high morbidity and mortality. So all eating disorders carry increased risk of death, both from the medical complications and from increased risk of dying by suicide. Anorexia nervosa is the mental illness with one of the highest fatality rates, secondary only to opioid use disorder. I also want to state eating disorders simply have a significant impact on people's quality of life. It is really miserable to have an eating disorder. It takes up a lot of headspace. It's exhausting. It gets in the way of like normal life events and experiences. So it also just has a significant negative impact on individuals' quality of life. We also want to talk about eating disorders because they're actually quite common. At any given time, over 30 million people in the US are struggling with eating disorders. So you're probably seeing these patients already and maybe not even realizing it. In adolescents, eating disorders are particularly common. They're considered to be the third most common chronic condition behind obesity and asthma. And recognizing an eating disorder can be a really important piece of the puzzle to understand the overall clinical picture. Sometimes it can kind of be the missing thing that kind of needs to get figured out to help someone move forward. Also want to talk about eating disorders because these folks fall through the cracks. So we hold certain assumptions about who has an eating disorder or who might have an eating disorder based on a variety of factors: age, gender, race or ethnicity, body type, socioeconomic status. Frequently, there's a lot of stereotypes around eating disorders, and I really want to break those for you. So eating disorders cross all races and ethnicities, cross all gender, sexual orientation. Individuals of all ages can struggle with eating disorders. Currently, I have patients ranging from about 10 to about 65, all in care for eating disorders at different points in their life. So it's really a very diverse group of individuals that can struggle with disordered eating. I also want to talk about eating disorders because of our own beliefs we bring to the table. So we all bring our own cultural beliefs, feelings, understandings about food, weight, shape, and health when we interact with our clients, with our patients. And as a society, we tend to put thinness and weight loss really on a pedestal and tie it very closely to health and wellness. When the reality of that is this is far less evidence-based than we're actually led to believe. And so it's really important to consider our own biases when we're assessing for eating disorders, treating our patients, including particularly anti-fat bias. This is a particular passion point of mine. I can talk for an hour about it. I won't here, but I just really want to allude to and acknowledge that we cause individuals harm due to conscious or unconscious anti-fat bias that exists both systemically within our systems and then individually. So what sort of creates eating disorders? How do they develop? So we understand the development of eating disorders sort of within the same biopsychosocial framework in which we sort of understand most mental illnesses. So there's a number of factors that may contribute to the development of an eating disorder for any individual. And every individual's story is different and unique, but there are certain themes. So first of all, there's a cultural component. As I alluded to, we live in this really thin is beautiful and thin is something to be aspired to culture, and that creates a lot of fallout. Um, Including a lot of individuals, some individuals at a very young age, starting on diets or being concerned about their weight and their image. Although not everyone who goes on a diet develops an eating disorder, it can be a significant precipitating factor. There's also a genetic component. We know eating disorders have a high degree of heritability, can be passed down from parent to child, both through genetic and learned factors. We also see alterations in the serotonin system, the dopamine system, and the opioid system when we look at individuals who struggle with disordered eating. So some real underlying sort of biological drivers behind eating disorders as well. And then finally, there's a lot of different individual factors that can contribute. One is a large role of early childhood trauma, and individuals who experience more trauma throughout their life are at increased risk of disordered eating. Also, different personality traits or features can put individuals at increased risk. So we tend to associate eating disorders with perfectionism, but eating disorders can also be associated with a high degree of under-controlled behavior and impulsivity as well. So sort of both ends of that spectrum. And then finally, lots of comorbid psychiatric illnesses can be sort of precipitating or perpetuating factors for disordered eating. I mentioned trauma, PTSD can absolutely be a significant contributor. Also, lots of folks with anxiety or mood disorders. Interestingly, significant comorbidity with individuals who are neurodivergent, who have autism or ADHD. Could also increase risk of disordered eating and eating disorders. So, when we talk about eating disorders, what exactly are we talking about? I'm going to walk through some of the different eating disorder diagnoses, just so you sort of have a sense of what those criteria are and what I might be looking for when I'm, doing a psychiatric interview, making those diagnoses. Now, I will say, these all come from the DSM, sort of our psychiatric Bible of diagnoses. Patients don't typically read the DSM. I mean, sometimes they do, but they don't necessarily fit into the discrete boxes. So I also fully acknowledge that these labels very much have their limits, but we're going to talk about them anyways because it's sort of the language we use to describe eating disorders. So first of all, the two you've probably heard of, maybe the most familiar with. So anorexia and bulimia, they have been diagnoses that have been sort of around the longest. So with anorexia, we get significant restriction of caloric intake leading to weight loss. And this is coupled with an intense fear of weight gain or behaviors that interfere with weight gain, along with extreme concerns about weight and shape. These are folks who are terrified and overwhelmed about restoring any weight, gaining any weight. With bulimia, a little bit different. We've got recurrent binge episodes where someone is eating an excess amount of food, a large amount of food in a discrete period of time. They're feeling out of control. They might be eating until they're like feeling physically ill. And this is coupled with some form of compensatory behavior to offload those calories. Classically, we think of purging by vomiting, but purging can also happen through the use of diet pills, diuretics, laxatives. Sometimes excessive exercise is used to sort of offload that caloric intake. It's got a frequency and duration requirement, so an individual is doing it at least weekly for at least 3 months to meet the diagnostic criteria. And again, we've got these excess concerns about shape and weight. Two diagnoses that are a little bit newer are binge eating disorder and avoidant restrictive food intake disorder. So binge eating disorder, similar to bulimia, we've got recurrent binge episodes, but it's not coupled consistently with compensatory behaviors. to prevent that weight gain. So they're not engaging in the purging. Again, same time and frequency requirements, at least weekly for at least 3 months. And they don't necessarily have the perseverative thoughts around body image. They certainly can, it's just not part of the diagnostic criteria. Avoidant restrictive food intake disorder, it's a bit of a mouthful, so we actually call it ARFID for short, is like anorexia, also a restrictive eating disorder. They're not getting in enough calories. The difference is the reason behind the restriction. So whereas for anorexia, we have weight, shape, and body image concerns, for ARFID, those concerns tend to be associated with the nature of the food itself. So it's things like concerns around textures or taste, or concerns about what the food will do in their body, such as having severe GI symptoms that aren't explained by a sort of GI diagnosis, or things like fears about choking. We see increased rates of ARFID in individuals who are neurodivergent, who may struggle with like a really narrow range of like textures that they eat. That's a pretty classic ARFID picture. And then the two sort of more grab bag diagnoses, a little bit broader, other specified feeding and eating disorder and unspecified eating disorder. So for other specified feeding and eating disorder, you've got symptoms of an eating disorder causing significant distress, but they don't fit in the other 4 boxes I just described to you. So this is kind of for the person who doesn't fit the other labels. For me, the most important one to highlight in here is atypical anorexia. So the name is really unfortunate. And if I ruled the world, we would change it because it's actually the more common form of anorexia. So the atypical is really a misnomer. So with atypical anorexia, you have all the features of anorexia, significant perseveration around weight and shape, significant caloric restriction leading to weight loss, but they haven't actually dropped into sort of that low weight state. So they don't actually meet the criteria for anorexia. We could spend more time thinking about how anti-fat bias might play a role here. We won't, but I will just sort of plant that seed. Then for unspecified eating disorder, this is helpful if you have a patient where you're like, there might be an eating disorder going on, but I either don't have time to do a full assessment right now because I'm just meeting them, or they're not actually at the spot where they're willing or able to open up yet around what their food behaviors are. So I don't have enough information to try to put them in one of the other 5 boxes. So those sort of broadly speaking are the eating disorders that we will be mostly focused on today. So who should we be screening? And sort of why do we need to do screening in the first place? So we really need to ask individuals about an eating disorder and about eating disordered behaviors because they tend to be very unlikely to volunteer this information. This can be for a whole variety of reasons. There's frequently a lot of shame associated with eating disordered behaviors. They're really ashamed of, the binge eating that they're doing at night or the purging behavior or how little they're eating. And so they're not going to come in and just share. Also, frequently, there can be aspects of the eating disorder that may align with their own goals and values. So they may be very hesitant to give it up when it feels sort of so enmeshed and entangled with who they feel they are as a person. And then finally, on some level, the eating disorder may be working for them. It may be serving, it frequently is, serving some purpose or serving some role in their life. So an example I see frequently, individuals with a history of significant trauma, maybe struggling with symptoms of PTSD. Those eating disorder symptoms, whether it's binging, restriction, or purging behavior, may be serving as a form of self-soothing or self-punishment or a way to feel a sense of control when nothing in their life feels like they can control it, or to control their body when that has not been possible for them in the past. So it can be really hard for them to think about giving up this thing that has in many ways felt so helpful to them and to their sense of safety. And so this really means we need to ask them. I will say the exception to this is sometimes it's sort of like in a case of Alice where the parents come in and say, hey, I think kiddo has an eating disorder. So sometimes it does come in that way a little more directly, but frequently it's not necessarily what they're walking through the door for. So who should we be screening? So the American Academy of Pediatrics actually advocates for the routine screening of all preteen and adolescent patients because it is just so common in this age group. So if you're seeing teenagers sort of in this role, to really be thinking about regularly doing screening for disordered eating and body image distress. For adults, there are fewer specific guidelines. From my perspective, I would love for you to screen everybody. And I know that that may not be entirely practical. So I'm going to advocate you at least think about screening high-risk groups. So as I mentioned, onset of eating disorder tends to be earlier in life. Doesn't have to be, but tends to be. So think about screening sort of younger adults. Also, high rates of disordered eating in the LGBTQ community, particularly amongst transgender and gender diverse individuals. So be thinking about screening there. Eating disorders tend to be a relapsing remitting illness. So someone may be doing just fine with their eating disorder and a big stressor happens and symptoms flare up. So anyone who's going through major stressors, think about it for those folks. We mentioned the heritability, family history. Anyone you're seeing for rapid changes in weight, think about it in those folks, and athletes tend to be at increased risk. So back to Alice. Would you screen Alice? I'm hoping you're all thinking yes. So we've got a young individual who seems to have some perfectionistic tendencies, baggy clothes or maybe weight loss here. She's withdrawn, could be comorbid depression, which could increase her risk of eating disorder, or could be just the eating disorder itself. And mom's noticing some changes in food behaviors. So we would definitely be wanting to think about screening Alice. So what are our options for screeners? I'm going to talk about screeners and I'm going to talk about some longer assessment tools. When we think about short screeners, we've got the SCOFF, we've got Screen for Disordered Eating, Eating Disorder Screen for Primary Care, and then there's a specific one for ARFID. There's a 9-item ARFID screen. All of these are 9 questions or less. I think all but the ARFID screen are like 5. So it could be done very quickly. If you're typically using like a PHQ-9 for depression or a GAD-7 for anxiety, you could think about sort of slipping one of these in there as well. So this is just an example of one of them, the eating disorder screen for primary care. Are you satisfied with your eating patterns? Do you ever eat in secret? Does your weight affect the way you feel about yourself? Have any members of your family had an eating disorder? And do you have have you struggled with an eating disorder in the past, or do you currently? If you could only ask them one question, that last question, just straight up, do you have an eating disorder, is the highest yield. It will, of course, miss people, but if we are pressed for time, simply asking can at least help open the door that you recognize that eating disorders exist, and can potentially help start the conversation. Variety of longer screeners available to sort of do more of an assessment and gather more data. I think this could be really helpful, particularly if you don't frequently see folks with eating disorders and you're like, I'm not even sure what I should be asking. These assessment tools are available online. I'm also happy to send you copies. These are all longer, dive a little more into the eating disordered behaviors. You've got some at the bottom there that are specific for sort of the ARFID rumination syndromes as well. But if you aren't into using a formalized screener, it's always a good idea to simply have a conversation. I think this can be really helpful in opening the door. I try to start by normalizing eating potential disordered behaviors and really bringing that non-judgmental stance. So saying something you like, half of when people are under a lot of stress, they'll eat more or less than they would otherwise. Does that happen to you? Maybe that happens to all of us, right? Like we're anxious before a presentation, and so we don't eat as much breakfast as we usually would, or we've had a rough day, so we maybe reach for some more ice cream or pasta or whatever that might be. That's all very normal human behavior and can just help start the conversation. When I think about having these conversations and I'm looking at symptom assessment, I'm trying to assess for symptoms in sort of 3 main buckets. These include eating behaviors, purging behaviors, and struggles around body weight and shape. And then also sort of in the vein of motivational interviewing, I'm asking questions around life impact. So I've just got some questions up here. I will just pop them up on the screen for the sake of time and let you refer to them later. I will highlight, though, one of my favorite questions is to ask individuals how the eating disorder is helpful to them, because that can start to get at the sense of like, hey, what role is it playing? And if we're going to treat them, how are we going to help sort of fill that gap that the eating disorder might leave? So back to Alice. You offer to check in. At first, she declines. No, thanks. Everything is fine. Very typical initial response. You try again later. You've got a relationship with her. You continue to work at it. So she agrees to chat. She shares that she's been feeling very stressed about school, wants to make the varsity track team. And she says to you, I'm trying to eat healthy and exercise. This is a very common way an eating disorder can start, with truly the best of intentions. We're all told to eat healthy and exercise all the time. When you ask her a little more detail, she says she's engaging in intermittent fasting, like most days. She's not eating all day, and she's running at least 5 miles a day. This should set off a lot of red flags. It does for me. So you're concerned. You talk to mom. You said, how about, can she go and see her pediatrician? So mom takes her in to see the pediatrician. Eating disorder work is always a collaborative, multidisciplinary effort. We really want to include medical providers in this. So at the pediatrician's office, her heart rate is noted to be low at 45. This will sometimes get dismissed because people will say, she does track and field. She's an athlete. That's why her heart rate's low. No, her heart rate is low because she has a restrictive eating disorder. Like, that should always be at the top of the differential when you've got someone with weight loss, even if they're an athlete. She's also got some orthostatic hypotension, suggesting that she's not hydrated enough. She doesn't want to be weighed, but pediatrician's able to get her weighed. And it is notable that she has dropped off her growth curve. So this is a kid who always tracked in the 75th percentile. That was normal. That is where her body is happy and content. And now her weight has dropped off. But technically, this means her like BMI, and I'll also talk about all the problems with that measure, but her BMI is in the normal range. So they get a little more history. Alice, she denies any sort of purging behaviors. She reports she'd like to lose about 20 more pounds. She's feeling very tired. She's struggling to concentrate. She absolutely does not want to gain weight, very upset around body image. So diagnostically, where does that leave us? As I mentioned, this puts us in sort of that fifth box, that other specified feeding and eating disorder or atypical anorexia. So we've sort of got all the hallmarks of anorexia: not eating enough, perseverative around body image. Her weight she's dropped off her growth curve, which sometimes the unique thing about adolescents, their weight may not have changed, but if she's grown taller and not appropriately tracked, she may still have dropped off her growth curve. But isn't yet in that quote unquote low weight state. So we would categorize this as atypical anorexia. And with that, I'm going to pass the baton to Dr. Goodwin.
Thank you, Dr. Riddle. So I am going to keep us moving through and want to make a report on, or want to make a comment on rapport. So as Dr. Riddle alluded to a little bit earlier, it can be hard for people to talk about this, especially the first time they open up about the struggles. And oftentimes there's, in some of the diagnostic criteria, even there's this tendency to deny the seriousness of the illness and not understand how serious it can be. We think of eating disorders as often egosyntonic, meaning that they kind of are congruent with what the person is wanting and they don't necessarily want to give it up, which is really different than maybe some of those other disorders like anxiety and depression, that people don't like experiencing that and they want it to go away. So when you have these conversations with someone, it's really important to have a lot of empathy, some curiosity, avoid judgment, be validating, try to jump into their world as much as you can. And really keep in mind your own emotion states, your own preconceived notions about people with eating disorders and who that fits and who doesn't, and really understanding that we each have our own relationship with our bodies. We each have our own story about our weight and our body shape and size and how we feel about that. And it's really important to keep awareness of that so that when you're talking with someone, you can truly kind of be focused on what's going on for them and their body, and how you can kind of express some curiosity and also concern for them.
hoping it'll, there we go. Okay, so in terms of approaching a discussion with someone that you are concerned about, it's often a great idea to take a little time to learn. So if you're here today, you're probably checking that box off. But take some time and learn a little bit about eating disorders and what could be happening. I always think it's really good to learn about anti-fat movements. I mean, anti biases, so that you are aware of those things as well. And then set aside a private time to connect with that person. So often it's best to say, hey, I want to talk to you about something. When do you have time? Versus kind of just jumping in and saying, hey, we're talking about something right now. So they have a little bit of time to prepare and also know that there's going to be a conversation happening. Share your concerns, express care. So generally saying like, hey, I'm noticing that you're showing up differently. You're wearing different clothes. You seem more withdrawn, more tired. What's going on? I'm worried about you. I care about you a lot. Again, oftentimes you can hit kind of that denial and that defensiveness. So really important to continue to lean in and say, hey, I can tell this is hard to talk about. Seems like it might be making you uncomfortable. I can totally understand someone asking you questions like this might be hard. I really just care about you so much, and want to be able to support you in whatever way I can. If someone is able to kind of share more with you, or they seem to have some openness, you might offer to get them some help. So saying something like, hey, are you willing to talk to someone? Are you willing to go to your PCP? Are you willing to keep talking to me about it, and just see where that open door is? And then reaching out to a PCP and other care providers can be really important. So in the treatment of an eating disorder, it's really important to have a team. Everyone that is on that team represents a different kind of specialty and can speak to that portion of how the disorder is working. And also it can help bolster motivation to get help when you have multiple people that are caring for this patient and encouraging them to get some help. If someone needs emergency medical care, really important to get them to the ER, call 911. There are a lot of medical complications with these disorders, which we'll talk about briefly in just a little bit, but really important that if you have concerns about someone's medical stability, you get them to the doctor ASAP. I will never forget I did an intake with a kiddo, and you can only see on telehealth from here up, and it was a telehealth intake. And even through telehealth, I looked at this kiddo and immediately was like, oh, you're really unwell and I need you into a PCP right away. And it's a good thing I did. And don't quite know how I had that radar, but after years of working with these folks, could just tell based on some of the cognitive pieces, because heart rate was in the tank. It was like at a 40. So really important to get folks to the right people if you have concerns. Also really important to collaborate with co-parents and parents, family members, so other people that care for these patients and are involved in their lives. They may know something is going on but have no idea what to do. You may have had parents who have tried to say something to their kids but have been pushed back and don't know how to make it better, feel like they've done things to make it worse. And so really important to reach out to parents, let them know that you're concerned, and help them get the support they need as well. And then, of course, seeking help, seeking that team, seeking consultation when you need it from people who specialize in this as well. So do's and don'ts. So do, as we said, share your concern, acknowledge the emotional distress, and the shame and the different experiences of anxiety that this may bring for folks. And then, remember to avoid things like you just need to eat more, you should just have a hamburger, you just need to stop this behavior, you just need to put down that food. Those can be really kind of minimizing to the experience that someone is having. And I, have had a lot of folks say, well, I just told them they need to eat more. And that's really hard for them. You have to imagine that, this really takes on almost a phobia feel, that people get really, really scared of putting nutrition into their bodies. And so they need more help, and, more coming alongside them to get through this. Also avoid making weight and shape comments, especially as the person begins to recover. So, saying things like you look good or you look healthy, that can actually be really triggering for the eating disorder. Even if it's meant in a positive kind of respect, it can be really, really hard for folks to hear. So really important to avoid some of those comments. And don't forget, this is a mental illness, it's not a choice. So, these folks are dealing with a complicated array of reasons why they have developed an eating disorder. And it can be hard to understand, but it really is something that it's kind of taken over their brain in a lot of ways, and it's kind of directing a lot of their behavior. So it's really important that you remember that this is not something that they're just choosing to do. It's something that is functional, that is related to the experiences that they're having, and they need lots of support. So once you've identified a patient with an eating disorder, then it's time to help them get the treatment that they need. We know that earlier diagnosis and treatment is associated with better outcomes, lower rates of relapse, and things of that sort. So it's really important that when you identify someone, we do whatever we can to get them in treatment, get them the weight stabilized, get them nutritionally stabilized so that they can recover. So a couple of comments about supporting the family. So if you are working with a kiddo or sometimes an adult, really important to get that family involved. So the first thing I want to comment on is it's really important to consider family dynamics, cultural, social issues that may come up in the conversation, and understanding, what that particular family may be struggling with, or how they represent themselves and what values are important to them, and really working within that system. Really important again to ask, is it a convenient time to discuss the issue? Begin by telling them that you're concerned for the person who potentially has an eating disorder, and focus on specific factual information. So we've noticed some changes, wondered if you've noticed anything. Again, a lot of family members are noticing something but don't know what to do about it. They may be particularly distressed because they don't know how to fix it. They don't know how to help. So it's really important to show that empathy and support without judging, making pronouncements or promises. Aim to open up that relationship. So aim to set up a supportive relationship. Be mindful that, they may feel like, oh my gosh, I haven't noticed this. I should have noticed this. How could I not notice this? Or, yeah, I've noticed. I've been trying to get her to eat, but I just can't even like get her to come to the table. So know that those feelings may come up. There may also be denial. There may also be, oh no, it's fine. She's just losing weight and that's fine for her to do. She needed to lose some weight. Some families will operate within that system, and it's really important to know that that can happen. And so, being able to join into like an empathy space, but also challenging some of those reactions can be helpful. Encourage them to access support, information, provide some resources. Ask the family what you can do. How can you be helpful? So again, if it doesn't go smoothly, again, there's times when they may minimize your concerns, they may decline a consent to a specialist service. In those instances, it's important to be persistent, be gentle, be validating. Often, if you're a PCP, this goes a little bit easier because you have a lot of the medical pieces to back up. But if you're someone who doesn't have those medical pieces on hand, it can be a little bit tough to continue to be persistent. And I would just say continue to, approach the conversation, be gentle, validate, know that it's acknowledge it's hard to talk about. Continue to reiterate that concern, tell them you're here for them to talk to whenever they need to. Again, if it's a medical safety issue, you may need to call 911, or, strongly communicate they need to get to a doctor. Maintain that communication with the child or young person in the family. Recognize this could be shocking for them. They may need a little time to process, and may not be acting out of the wisest part of their minds because they're triggered emotionally. So coming back to the conversation after things have settled just a bit for them can often be helpful. So in terms of a treatment team, so as we're kind of trying to link people up with care providers, treatment team generally consists of a primary care physician, a registered dietitian, a therapist, and the patient and family. And so getting all those people on board is incredibly helpful. You have somebody monitoring the medical pieces, the growth charts, making sure someone is safe. And then you have dietitians that are helping create meal plans and figuring out a way to stabilize nutrition and weight if needed. And then you've got a therapist working on the emotional pieces. And then the patient who is involved in helping make decisions about what they need, and family who is talking about how to support them. So in addition to this, you also often will also have a psychiatrist that can be added to the team to help with medicines that might be helpful for managing anxiety, depression, some of the eating disorder symptoms. It can just be another layer of support working on some therapeutic interventions and supporting the team as well and the patient. So in terms of where to treat, there's a large level of care spectrum for eating disorder. And a patient really needs to be assessed in terms of a variety of different areas to know what is going to be the best placement for them. So the higher levels of care can be tough for folks who have Medicaid and Medicare to access. It's getting a little bit better. And as Dr. Riddle said, our system that we work in is working really hard to make sure that these patients can get into our care. But really important to remember, we've got to find the right level of care for folks. So in terms of considering level of care factors, you want to be thinking about medical complications, suicidality, and safety. Small comment here that eating disorders have quite a high rate of self-harm and suicidality comorbid with them. So it's really important that if you're doing a screening, you may also want to screen about safety. We also need to be looking at target of body weight target and percentage to that. Remember that we want to be mindful of everyone has their own target weight that they need to get to, and that may or may not be within what a BMI range says is normal or whatnot. So just really making sure that you're paying attention to where does this person need to be for their weight and their body size. We want to think about things like motivation for recovery, comorbid disorders, environmental stressors, amount of structure that's needed to help somebody weight restore or weight stabilize or nutritionally stabilize, their ability to take care of themselves, control exercise, control purging. So I put a link here to medical guidelines for the treatment of eating disorders. So I'm not going to go through all of these because you have the slides, but this is the inpatient level of care. It's going to be the highest level of care that we have for folks with eating disorders. So these are people that are really compromised medically and need a lot of monitoring to make sure that they can stay safe and alive, to be very blunt about it. So really thinking about electrolytes, heart rates, are they, how's their nutrition, stabilization, blood pressure, safety concerns. They really are not folks who are motivated. They need a lot of support to make forward movement in terms of movement towards health, and they need a lot of supervision. So yeah, really thinking about these folks as very compromised medically. And then we have the residential level of care. So these are folks who still need some frequent lab monitoring, medical monitoring. Their vital signs may show some signs of irregularities, but they're more stable than they would be at the inpatient level of care. They may need a tube, a nasogastric tube, to help them get nutrition in. They've got family systems that are kind of helping support them. Still pretty hard to be motivated at this level of care, and need a lot of structure and safety containment sometimes. PHP is basically a day program. So these typically run from, 8 to 5 or 6 and support folks who are pretty medically stable. They don't need daily labs. They don't need IV fluids or nasogastric tubes. They have, some motivation to move forward. The social support system is kind of intact and supportive, and they are able to make some, kind of like structural changes to their life in terms of exercise, reducing purging, and they're safe. And then intensive outpatient usually is a couple days a week. So usually it's like 3 to 4 hours a day. Again, generally medically stable. They need some structure to weight restore and weight stabilize, have some supervision at meals, but really are able to kind of like move themselves along in a lot of ways, or have a really strong family system that can support them. And then finally, outpatient level of care, medically stable, no safety concerns, pretty close to where they need to be in terms of their weight target, pretty motivated, strong social support system. They're able to make gains, able to control their behaviors, and really move towards a value-oriented life that they would like to have. So going to get into treatment, these are kind of be our 4 pillars of treatment that we're going to talk about. So pharmacology, psychotherapy, eating disorder behaviors, and addressing malnourishment. First thing we're going to do is talk about malnourishment, because it is really, really important that this is a priority when you start working with someone with an eating disorder. So the first thing I want to talk about is just medical evaluation. So in terms of malnourishment, there can be some very serious medical complications that are secondary to starvation or binge purge behaviors. Really important to not make assumptions about medical stability based on someone's weight and how they're presenting to you. They could have lost a considerable amount of weight and their body could be in a very serious condition, even if they look okay to you. So really remembering there can be very serious medical complications that really need to be assessed by a medical doctor. Often those medical complications, when we're talking about restrictive eating disorders, are related to organ dysfunction due to malnutrition, really starving all the organs of things that they need. There's impacts on the brain and ability to process information, and really, really a big impact on the body. And then for binge purge behaviors, this is often related to things that happen when there's a lot of purging happening and frequency of that. So esophagus issues, stomach and digestive issues. So all those things also need to be paid attention to. Electrolyte different dysfunction. So really important to pay attention to those. And if you have more questions about medical pieces, Dr. Riddle will talk a little bit more about that at the end if you want to pop questions that you might have into the chat. So in terms of addressing malnourishment, the majority of patients that have an eating disorder have some degree of malnourishment that really needs to be worked on. So, early in treatment, we are working as a team with medical doctors, dietitian. This is a little less in the therapy realm. And this is where, if you're a therapist, rely on those people that are dietitians and medical doctors to help you know where your patient needs to be. But we're going to be identifying a target weight based on that person's body. So based on their weight history, on their trends, and really kind of developing that idea of where they need to be. And it may or may not be close to what they think is their ideal or what is considered ideal for their body. So really thinking about that person and where they need to be. This is incredibly important because when someone has an eating disorder, their brain is really deprived of a lot of nutrition. And so is their body. But if I'm a therapist who's wanting to work with a patient on their eating disorder, but they don't have the nourishment that they need, it's going to be really hard for their brain to do the complexity of normal talk therapy without having more nutrition to help their brain process the information. So we always talk about when you are working with someone with an eating disorder, it's really important to get them restored nutritionally as soon as you can, and know that you may have to put aside some of the talk therapy pieces until they have more nourishment so their brain can process it. There's a graphic here about health at every size. This is a really important movement to know about, really talks about how, again, there is a place where everyone's body functions best, and it may or may not align with what is considered kind of ideal or what's on a BMI chart. So really, really important to understand that there can be health at lots of different sizes. So I did a presentation years ago for some school-aged kids, and had someone stand up and share that she had recently done a presentation with another person where two people had gone to see their doctor. One was in a thin body, one was in a larger body. And the person in the larger body actually had much better health markers than the person that was in the thinner body. And so really keeping in mind that folks can be functioning at a very, very good place in a larger body size, and that we have to understand that body size, as we look at it, doesn't communicate health. We have to know what's going on with the body and understand the markers that are happening. I was really proud of that school-age kid that spoke up about that in the middle of all of her peers. Still was just floored about that. So in terms of addressing malnourishment, so again, when you have a dietitian on board, they're really going to help focus on this. A medical doctor also can, if someone is having trouble adding another team member to their treatment team. But for those restricting, initial treatment often focuses on increasing caloric intake. We kind of start at 1,200 to 1,400 calories a day, gradually increase to 3,000, 4,000, depending on the rate of weight gain. The target weight gain we want to go for a week is 2 to 3 pounds. If someone's lost a considerable amount of weight, we have to be thoughtful about things like refeeding syndrome and really making sure that we're refeeding at the right rate for the person, that their body can handle and be okay at. And often we're asking somebody to not exercise so that their body can get rest, can heal, and get what it needs to. So in terms of eating disorder behaviors, things that may come up in terms of how someone is orienting towards food. So they may have safe, unsafe foods. They may have allergies that they're reporting that have really onset with the eating disorder. So this is apart from like, there are very true allergies that someone can have, but oftentimes an eating disorder will kind of limit the amount of foods that someone is allowed to have. There is some research that I was actually a part of that shows that folks that have eating disorder have much higher rates of vegetarianism and veganism. And so just knowing that sometimes that eating disorder can step into those preferences and have some impact on it. Again, totally fine to be a vegetarian, vegan, have allergies, but when it's happened with the onset of the eating disorder, it's important to just acknowledge that it may be an eating disorder rule that's come up. So often portioning gets changed, pacing can get really slow. There can be excessive exercise happening. I've had folks who have just kind of like a compulsive need to do squats until they feel like they've met some kind of place in their mind that makes it okay to keep going. You can have purging behavior. Timing of meals can get really long. It can also be really short if someone's struggling with meals. Fluid intake can get restricted. There may be rituals like circular eating on the plate, or I have to eat all of this food before I eat this other one. And then hunger and satiety cues are really impacted. So as tough as this is sometimes for our folks, that they sometimes need to eat when they aren't hungry. And so a lot of our folks that are weight restoring complain about feeling full and not hungry, and that's something we have to ask them to kind of push through, because their body needs more food, but it's not used to having that food, and it's working on repairing all the organs. And so that can be a really uncomfortable part of the process of weight restoration if someone needs to do that. So we have structured meal plans, often working on expanding the quantity and variety of foods. We're looking at activating support and accountability around meals. So often we're having folks keep a food record. There's various apps out there like Recovery Record that will let a client connect with their care providers, and they can take pictures or report on what they're eating and get feedback. We're often recruiting family members to help support. I'm going to talk a little bit more about this later. And meal support at higher levels of care is offered. So in our facility, we do meals with our people all day in residential, and then most of the day in PHP and some of the day in IOP. So really providing folks with staff support and people who will help encourage them or come alongside with them if they're having difficulty. Meal support can also be a part of outpatient sessions. So if, back when I was in private practice, often I would eat with people. And so, really working to help someone in the space that they're at. So if you have someone that really is struggling to eat, it may be most helpful to practice eating with them, helping them get that food in. Also doing things like exposures to restaurants, grocery stores, cooking, knowing that sometimes the grocery store can be really tough for people because there's labels available. They can look at the labels. The eating disorder has lots to say about those things, can be really overwhelming. So helping patients get used to getting themselves food can be a big thing. Had a client that her eating disorder really activate in that she just wouldn't go to the grocery store. If she had the food, she did okay. But if she didn't have the food, she didn't eat. So we really had to work on how do we make sure that you have the access to food in your home so that you can take care of yourself. And that would get even more difficult for her when there were stressors in her life. So plan for allowable exercise. So working with team members. So as a therapist, psychologist, I would never make a recommendation about whether someone should exercise or not. I would be deferring to the PCP or dietitian. So again, just speaking to that level of importance of having people that are on your team. And then in terms of psychotherapy, my favorite part. So when we're talking about treatment for folks, I'm going to break this down based on the different eating disorder presentations. So for adolescents and young adults, gold standard of treatment is family-based treatment. So there is a version of family-based treatment called transitional age youth that can be used for folks that are like 18 to 25. It's a little bit more of a flexible format. But I love FBT, and I'm actually going to talk about it a little bit more in a couple slides. So I'm going to whiz by it right now, but it's really one of my very favorite things. And then in terms of on this other side of the slide, so again, commenting on weight restoration is so important to get somebody enough nutrition that their brain can process information and they cognitively are kind of fully present. Emotion-focused family therapy partners super well with family-based treatment. I will also talk about that one a little bit more. Acceptance and commitment therapy is my personal favorite. If I'm not doing family therapy, this is the one that I love to do with patients. It's just a really lovely way of having someone kind of assess what their true values are. And when you're working with an eating disorder patient, often the eating disorder kind of takes over their life, and the eating disorder has its own value system. And that value system is often very different than what the person's value system is. And so when you're able to help someone differentiate that, it can be really helpful. I often use the metaphor of the Mean Girls movie because you see Katie Heron come into this new school environment, and she is this math person who has all these kind of cross-cultural interests, is very kind. And then over time, you see her start to become this mean girl who starts to prioritize romantic interests, clothing, kind of putting down other people. And then, sorry, spoiler, but at the end, she kind of comes back to herself. And so, I think about that oftentimes. I use that with clients and eating disorder, really starting to differentiate. Hey, like, what are your true values, and what is it that the eating disorder is valuing? And how do you differentiate that as you're going along in treatment? And so helping someone do that can then help them engage the other skills, which are things like recognizing when they're having a thought that it's just a thought, and they get to decide whether they're going to act on that thought or not, and making room for emotional experiences and recognizing those experiences that they're having in life and being present. So I love acceptance commitment theory. We could talk about it for a whole hour, so I won't do that because then you wouldn't get the rest of the presentation. So there's also cognitive behavioral therapy, eating disorder focused, that can be really, really helpful for folks, understanding how thoughts impact behaviors and emotions. RODBT really focuses on these ideas of openness, flexible control, and social connectedness. It's really geared for folks that are more on that over-controlled, perfectionistic kind of range of personality. It helps them to be more open, helps them understand what they're socially cueing to others, and how to kind of be more flexible in life. DBT is a great set of coping skills. It's generally for folks that are more under controlled, so people that tend to be more expressive, impulsive, open about their experience. But it's got a great set of distress tolerance skills that can be really helpful. And then motivational interviewing is a great tool to have on hand for folks that are struggling to be motivated to go to treatment. Really, really emphasizes this idea of coming alongside someone and working with their resistance and being curious about it, and helping explore kind of the pros and cons of behaviors they're doing, and different things like that. So for bulimia and binge eating, again, for adolescents, family-based treatment is kind of the gold standard at this point. We also know that cognitive behavioral therapy, dialectical behavior therapy can be helpful. These folks tend to be less over-controlled and more under-controlled. So that's why DBT is here and RODBT is not, but you can certainly have someone that is doing binge and purge behaviors that is more over-controlled. And then again, emotion-focused family therapy. So for DBT, we're talking about generally 4 to 5 different sections. We're talking about mindfulness, or we're talking about how do you regulate emotions, how do you tolerate distress when you can't make it go away, how do you tolerate that the distress is there. This can be a really important set of skills for folks that are trying to manage discomfort with fullness and getting on a meal plan and having to just tolerate how that feels. So there's some really great skills to give to folks to help just tolerate difficult emotional experiences, and then how to be interpersonally effective. So ARFID treatment, this is, relatively new diagnosis. We're still working on getting the best interventions. This is a new book that came out a couple of years ago. I've really liked it. It does a lot of providing education to families and kids about ARFID that I think can be really helpful. I think often folks with ARFID can be misunderstood by providers in their lives. And so I've had folks that have come to me with this history of ARFID, but that have been told a lot of things about why they are the way they are. And when they hear about ARFID and hear about the education that this book provides and that I can provide to them, it's incredibly validating. They're like, oh gosh, I'm not just this like weird picky eater that everyone doesn't understand, or I'm not doing this just to try to get my way, it can be really, really validating for folks. There's also a family-based treatment perspective on ARFID that just came out as well. So these things are currently being studied, and we need some more of that. But in terms of the treatment of ARFID, it really depends on the subtype. So there's generally three different types of ARFID that we talk about. So restrictive ARFID are folks who really struggle with feeling hungry and having a drive towards food. And so for these folks, structured eating can be really important, and then working with the family, if they're a kiddo, to help the family support them with a structured eating plan. And then CBT can be really helpful to help target kind of dysfunctional thoughts and problematic thoughts that can impact the drive towards food. For avoidant and aversive, so avoidant is folks that have had kind of a negative experience with food. So maybe they've had a choking or a vomiting episode and are scared to eat food. And aversive is when you have that bigger sensory experience of food. So really limiting the variety because they have a very strong reaction to food, and a lot of things don't taste very good for them. So for these folks, it can be really important to understand what are they coming to the food thinking. So I've had folks come and say, well, I'm sitting here looking at this food and I'm already telling myself I'm going to vomit. It's going to taste gross. I'm not going to be able to do it. All of those thoughts create a cascade of emotion and behavior experiences. So if I approach a situation with all that going on and I'm starting to get anxious about it, my body is going to tighten up and tense up, and all of the things that help me swallow food are also going to tighten and tense up. So really helping people understand, what am I thinking about when I approach this food, and how do I cope with that? What do I do in my body, whether that's progressive muscle relaxation or starting to work on neutralizing some of those thoughts so that they can approach it without having that cascade that could impact how the meal goes. So for these folks, we're often thinking about exposures, and sometimes this can look like, so if they have had a lot of kids really struggle with pizza, and that's a big one for social reasons. And so I've had a lot of kids come in and say, I just want to be able to go to a pizza party with my friends and eat the pizza. So that exposures might just look like having a piece of pizza sitting next to them at first. And then maybe it's a small kind of lick of the pizza or a smell of the pizza. So it's a very gradual exposure process to help somebody integrate new foods, and family is often very involved in that. There can also be mixed presentations. So this can be a variety of the different subtypes, or ARFID plus is someone who has ARFID and then they start to have weight and shape concerns that begin. So it's a little bit like an anorexia mixed with ARFID. So I couldn't get through this talk without giving you a little bit of information about family-based treatment. I'm going to go quick, but this is really an outpatient manualized model. It's really meant for folks that are kind of medically stable. It tends to take 6 to 12 months, 10 to 20 sessions. It can be the whole family together or parent only coaching. There's 3 stages. The first stage really focuses on weight restoration, healthy eating. There's a lot of parental empowerment that happens in this stage. So really helping parents step into the role of helping refeed their kiddos, and essentially saving their life from their eating disorder. So parents do a lot of the coaching. They do all the plating and the portioning of food. They do all the encouragement of the meals and making sure to kind of set the boundaries and limits so that folks are getting the nutrition that they need. And then stage 2, you're starting to return that control back to the adolescent. So once they are more stabilized and they're able to fight those eating disorder urges, they start to take the ownership of their food back. And then the third stage is really when the eating disorder has mostly improved and they're really able to feed themselves consistently and well. This was when I first learned about this, I had studied adolescent psychology for a long time, and I was like, wait, they're supposed to be working on independence. And this model really goes back to a more dependent stage where parents are highly involved. And I initially was like, wait, what are we doing here? I have absolutely fallen in love with this model because it helps kids get better. And so the rationale really is that when the eating disorder has taken over the brain, we really have to come alongside them to help be their ego strength, because that eating disorder is so loud that it's hard for them to make wise decisions about what they're going to eat, and they don't have a fully formed brain yet to begin with, because they're teenagers and kids. And so it's really about empowering parents to help come alongside their loved ones. So it's a great model. So partnering this with emotion-focused family therapy, that helps to uncover family patterns that need some work. It really helps parents learn how to do coaching, specifically emotion coaching and the behavior coaching. It helps identify places where parents are getting stuck and why. So often when parents are faced with their kiddo having an eating disorder, they have a lot of fear, they have a lot of hopelessness, helplessness. They might feel some self-blame, some shame. And so those patterns tend to result in things like denial or defensiveness or avoidance of the issue, or sometimes accommodating to the eating disorder, allowing that eating disorder to have what it wants. And so being able to work with the family and parents to understand these things and help them understand how to cope with how they're feeling and all of this can be really helpful to help them help their loved one. So I already kind of spoke of this a little bit, but the role of the dietitian is really important in the process. They can put together great meal plans that will really help someone honor their food culture and things that they find important while also getting nutritionally stable. They can help with food exposures, provide initial nutritional counseling, also provide support regarding physical activity and how much somebody should be doing. And then just to go back to our case study, so we have Alice. So Alice ended up starting with an outpatient team, but there was a lack of agreement on weight target. So again, we're talking about atypical anorexia. Kiddo's technically in the normal range, but has lost considerable weight, has fallen off the growth curve. So patient ended up seeing a psychiatrist and was prescribed some Zoloft for anxiety management, started the FBT family-based treatment process, but that stalled after 10 pounds of weight gain, largely due to family just had a lot of responsibilities and couldn't quite provide all the supervision at home that kiddo needed. And again, there was a lack of agreement on the weight target. So there were some members of the team that felt like patient was kind of okay where she was, and others who felt like she needed to gain quite a bit more weight to get back on her growth curve. So kiddo was ultimately referred to higher level of care. However, even in that higher level of care, which I will say was not our system, to be clear, even with that higher level of care, there was a lack of agreement on the weight target, and the patient continued to struggle until she reached her weight target that was based on her growth charts. So again, I see this time and time again that when we don't get someone back to that weight that they need to be at, they continue to struggle because their brain does not have what it needs to recover and the organs don't. So it's so important to look at those growth curves and to really think about your patient and make sure you're getting them to a weight target that is right for them. So at this point, I'm going to hand it back to Dr. Riddle.
Myself off mute, that'll help. Okay, I'm going to finish this up in 4 minutes. Let's see. So meds. The short version of the story about medications is they are not the answer for eating disorders. We really just use meds to treat the psychiatric comorbidities primarily. For anorexia, meds tend to have limited efficacy, particularly when someone is low-weighted. There's no FDA-approved meds. There's some evidence for antidepressants to help prevent relapse once someone has weight restored, and some evidence for atypical antipsychotics to help with weight restoration. In bulimia, SSRIs are typically first line, and Prozac is actually FDA approved. Do avoid Wellbutrin due to increased seizure risk. And then for binge eating disorder, we again have the antidepressants as first line meds, and lisdexamfetamine or Vyvanse is FDA approved. But again, all of these meds have pretty small overall effect sizes. And so really the nutrition and therapy and work with the team are the most therapeutic components. So really we sort of, I do prescribe medications, but again, I'm primarily treating other things that the individual is struggling with. I really want to impress upon you that these patients absolutely do get better. I think there's an impression that eating disorder patients, oh, they're just like chronically ill and really difficult to deal with, and nobody ever gets better. And that is not the case. Recovery certainly has its ups and downs, but these folks can have a really optimistic outcome. So some studies have suggested, I'm actually going to bump to this next slide. recovery, full recovery, so like without eating disorder symptoms, approaches 80%. But that's if you look about a decade out. So this is really a marathon and not a sprint. So you may be seeing someone for just a very small part of their journey, maybe just the beginning of their journey. But I really do want to provide a lot of hopefulness that these folks can experience significant improvement in their symptoms and in their quality of life, and frequently do even over the relatively short period of time, for example, that we get to see them at a higher level of care. And then finally, I wanted to talk briefly about resources. Dr. Goodwin and I just selected some of our favorites to share. There's a lot more out there. I really want to highlight the book Fat Talk. I recommend anyone who has a body should read this book or listen to it on Audible. It is just really excellent look at anti-fat bias. It's particularly looking at kids and parents, but truly, I believe it's beneficial to everyone. Also highlight some of our favorite podcasts and then websites with a lot of other resources. We are also happy to be a resource to you. So I've actually put the contact info for our professional relations liaison person, Betsy. Betsy is great, and I spelled her name wrong. It's not Bestie, it's Betsy. I will correct that. Typo on my part. Betsy is great and frequently knows things about the system that we may not know. So if you're like, hey, I have this Medicaid patient, do we take that form of insurance? She can help answer those questions or connect you with us if you have more questions. After this presentation is over, weeks, months from now, whatever, feel free to reach out. We are happy to answer questions and be a resource to you. So, hey, we did it on time. That is the end of our presentation. I'm happy to take questions. And I can stop share.
Goodness, Natalie, Megan, thank you so, so much. This was so informative. Everybody is saying thank you so much. This was excellent. We have a lot of questions, a lot of great questions. So everybody, please be patient. I will try and we're going to get to as many questions as we can. There's also some comments in here. So I think I'm going to move us forward to the questions. First one is, how does someone know if they are binging versus eating a normal amount for those who tend to feel shame about eating?
Oh, this is such a good question. I have my patients are feeling like, well, I feel like I'm binging, and I'll be like, but do other people feel like you're binging? So sometimes it can be helpful to, I try to have people not compare what they're eating to what others are eating, but sometimes a little bit of comparison can be helpful in terms of sort of checking yourself. I will say features for binge eating include really that feeling out of control aspect and feeling physically ill at the end, really eating a large caloric amount. We're not talking about you got a second bowl of cereal, like you were hungry and you got a second bowl of cereal. That's not binge eating. That's normal. You were hungry and ate more. I think other key things to think about are compensatory eating. So sometimes we'll have folks who really aren't eating most of the day because they're trying to be really good in diet, or their day got busy or something like that. And then they're eating most of their calories at night. And so sometimes we label that binging. Sometimes it's just we could eat more during the day. That'll decrease. Which can also, there's often a restrictive component, honestly, though, to binge eating disorder. That is a common sort of restrict binge cycle. But I think it's a really good point. I don't know, Dr. Goodwin, if you had particular.
Yeah, I mean, the only thing I would add to look for, so folks that have binge eating often have a lot of shame around the behavior. And so may not want to tell you about many of the details about what's going on, or may kind of experience some embarrassment as they're sharing that. And so I think that's one thing to look for. And then I generally try to get an idea of what somebody is eating. So I have them, okay, you said you binge ate, tell me what you ate during that time. And usually that helps me understand if it's just them enjoying food and eating more of it because it tastes good or they're really hungry, versus when it's a binge.
Right.
I also feel like this is a sort of side tangent, but sometimes folks who are in fat bodies get labeled with binge eating disorder simply because of their body habitus, not because of their actual behavior. So I do think, again, that's where that anti-fat bias can pop in.
Yeah.
Can ARFID also be associated with a patient's perception on food's nutritional value?
So what they may be alluding to is orthorexia.
Yeah. And that was the next question.
Okay.
Yeah. Is orthorexia considered an, so with that, so is orthorexia considered an, quote, other specified eating disorder? So maybe grouping those two questions.
Yeah. So for those who don't know, orthorexia are individuals who are really focused and perseverative around healthy eating, however they may define that, all organic, no non-processed food, whatever that looks like to them, and it can be different to different individuals. It is not a diagnosis in the DSM, so we're sort of left with what label do we drop them into, mainly for billing purposes, because honestly, the treatment is going to look the same regardless of like which other label I drop them into. Sometimes I would drop them into an OSFED label. Sometimes it might be ARFID. Sometimes there might be enough body image component that I would just label it anorexia anyways. And it's again going to be a similar approach of like, how do we increase the flexibility, the quantity, variety, and frequency of their food intake and help challenge some of those intense beliefs around food that may be getting in their way to like fully engaging in the world. Like, are they not able to go to a potluck and eat food because none of the food isn't perfect enough?
Got it. So this person's saying, I hear different responses. Can you share your thoughts about doing trauma therapy while there is an active disordered eating?
Yeah. You want to take that one?
I can take that one. So at the ERC Pathway System, we offer cognitive processing therapy as the target for post-traumatic stress symptoms. So, when someone is really actively in their eating disorder, we're really needing to help them weight restore. But if they've had trauma that is perpetuating the eating disorder, we really need to figure out when and how to integrate that. So, generally, what I'm doing is having a conversation with the person about where they're at, how they're feeling about that. And if someone is kind of readily working on their meals, so, for me, it's like, I got to get the nutrition in. And if the nutrition's not getting in, I'm doing meal support with the person to help them get eating and teaching them the stress tolerance skills and grounding skills, which is all part of trauma treatment. And then when someone is kind of consistently eating, I might be able to switch to working more towards a specific trauma approach like CPT. So, I think as we've talked about, that weight restoration piece is so important. So I think and weight stabilization, I think, my first thing is get them eating and get them getting some nutrition in, and then integrate trauma when they're able to keep that nutrition in. Because if you do trauma work and they're not getting any nutrition in, it's going to be hard for the brain to actually do what it needs to do, resolve some of the symptoms around the trauma. Anything you'd add, Dr. Riddle?
Yeah, a couple of things. I think people underestimate how cognitively impaired eating disorder patients are because they talk a really good talk.
Yes.
Like your restrictive eating disorder patient can like talk you out of paper bag. Like they can seem totally cognitively intact and they really can't get it. They truly cannot without the nourishment on board. So totally agree with Dr. Goodwin. Like we have to be getting consistent nourishment to really dive into that trauma work. Now for someone who maybe doesn't have a restrictive eating disorder, maybe they're more engaging in purging behaviors or they're more binge eating, self-harm, those sorts of things. I think you could start the trauma work like pretty early on if they're sort of getting consistent enough nourishment, because those folks frequently have a comorbid trauma history. I will also just say to the question asker, you've heard different things because the field believes different things at different times, and our own approach has shifted over the period of time that I have been here. So I don't think there's like a perfect right answer, but I think there's a lot more openness now to like doing the trauma work, even while there are active eating disorder symptoms.
Yeah.
Great. Thank you. And just so people know, yes, we are getting shorter on time, so I may skip around on some questions. I do apologize, but we want to get in as many as we can. So next question is, for people that practice in rural areas where specialized ED care is not available, Can you talk about how someone who is a rural, more general mental health practitioner can work with patients who have ED? This person believes, people are fear that people are slipping through the cracks
Yes.
and there's not a lot of resources.
Yeah.
This is where COVID did us a favor.
Yeah.
There's so much telehealth eating disorder treatment available. I would say that is a huge boon and super helpful. There's also a lot of eating disorder support groups that are online and facilitated. Liberating Jasper is a great one based in Washington. So sometimes for folks in rural communities, they might miss out on the connection with other individuals who are struggling. So getting them connected with support groups can also be great. What good one do you have?
Yeah, and I'll just comment that, look for things like, so the psychology world has PsyPact now, which means that a lot of psychologists can operate in other states. So look for folks that have that designation. I have that designation. And then also a lot of group practices have people that can practice from multiple states. And I will also say our entity has a virtual IOP option too for folks. So there's often virtual programs as well.
Great information. This other question is, this person is a case manager at a community mental health clinic, and was wondering if you had any tips on how a case manager could help a client with ED and not step over the line of therapy. So some things that possibly a case manager on a team could do, because in community mental health settings, we all are coordinated teams.
So one driver of eating disorder behaviors is food insecurity. For folks who are food insecure, that can really contribute to like binge restrict cycles and all sorts of other eating disorder behaviors. So I think about, connecting people with community resources to make sure there is enough to eat at home. I also think about maybe connecting with those support groups feels like could be potentially within the realm of case management. I also think sometimes these folks just have a hard time just navigating the system and calling people to set up appointments. Like there's so much ambivalence around the eating disorder, like even setting aside time to help someone make some phone calls to get more support, I think could be a really helpful role.
Yeah, agree.
Great. This is a couple questions about medication. So I'll kind of read both the questions first. Can you comment on the role of mirtazapine for appetite stimulation and duration of use once weight and appetite are stabilized? And then the next question is, can you talk about how Ozempic and other meds like it have impacted your ED work?
Everyone wants mirtazapine to work and everyone wants Zyprexa to work. There's more evidence for Zyprexa. Mirtazapine doesn't seem to be any more effective than the other SSRIs. Like, I know it makes sense why it would work. And so feel free to use it for depression and anxiety. It tends to not help with the eating aspect as much. The one exception to that, I will say, is I've had some success with it with ARFID folks with primary nausea that's driving their restriction. So sort of some of the anti-nausea properties of the mirtazapine can sometimes be helpful for them. So that's where I found I'm most likely to reach for the mirtazapine over something like Prozac or Lexapro or anything else. Ozempic. Yes, so this is all really fascinating and problematic, and I think impacts all of our practices in all sorts of different ways. A couple of comments from an eating disorder perspective. I've absolutely had eating disorder patients abuse Ozempic. I have one who purchased it off Reddit from who only knows where. Have also had individuals with a history of one type of eating disorder, so had more of a bulimia or binge purge sort of picture, got on Ozempic for their legitimate diabetes diagnosis, like that was a real diagnosis that they had, and then ended up with a very restrictive eating disorder, like hypoglycemic, lost a lot of weight. So I definitely think that providers in the community who are prescribing Ozempic really need to think about what they're doing, and make sure that they're doing a careful screening for eating disorders. I also think there's really interesting commentary about how it interplays with anti-fat bias and our beliefs around weight loss and access. There's a great maintenance phase podcast about it. Aubrey Gordon's fabulous. So yeah, if you look at maintenance phase, wherever you get your podcasts, there's a good one on Ozempic.
And we have a question. Can you talk about best practices for treating, is it pica in adolescence? And is that part of eating disorders that you deal with? PICA.
I don't do a whole lot of treatment of pica, so I feel like I would have to phone a friend. But Dr. Riddle, I don't know if you have anything.
Yeah, I mean, we don't tend to see a lot of that in the population we treat. I sometimes think about it a little bit more in folks with neurodevelopmental struggles. Things to think about. I think a really careful medical evaluation is important to make sure there's not a sort of an underlying medical component. I have had folks, this is a little bit like pica adjacent, who are sort of swallowing as a form of self-harm, swallowing non-food objects that can be really challenging. And I think we're sort of leaning in there to a lot of the DBT principles in terms of like distress tolerance, impulse control, also trying to figure out like some of the why behind the behavior. So those are some of the things that I think about for that diagnosis.
Great. Well, we are at time. I am so sorry if we did not get to your questions. You do have a copy of the slides. We very much thank everybody for joining today. Please do fill out the survey. Also, you have Natalie, Dr. Riddle and Dr. Goodwin's contact information. If you have any further questions, please reach out for consultation or just get your questions answered. Thank you so much, everybody, for being here today. Thank you, Dr. Goodwin. Thank you, Dr. Riddle, for being here and sharing your wisdom. It's so helpful.